Welcome again everybody to a new session in this session or video we're going to discuss an important issue which is sometimes mixed or misinterpreted as disease, and this is the mental foramen and its position in relation to the apex or the root of the lower premolars. Mental foramen, as we know, it is the exit of the inferior dental canal, and it is rounded in shape. It is located, the foramen exits buccally from the buccal surface of the mandible, and it represents the exit of the mental nerve and blood vessels that would continue forward to supply the lower lip. The mental foramen differs in its shape. Mostly it is rounded, and in other cases you will find it as rhomboid, or sometimes it's simply an irregular foramen. Either way, the position of the mental foramen, sometimes being in close proximity to the root, sometimes it is misinterpreted as a radicular pathology in relation to either the lower first or the lower second premolar. I think it is better to, before we go to the periapical radiographs, we would like to have a look at the course of the inferior dental canal and the from its start to the exit, and the best view that would show us this is the OPG, because it covers the whole mandible from right to left. The inferior dental canal starts from the mandibular foramen in the ramus of the mandible on the lingual side, and then this will represent, of course, the entrance of the inferior canal, inferior dental canal nerve or bundle, blood vessels and nerve, and then it goes downwards and it extends in a downward and then a forward direction, and then it loops back and then exits into the mental foramen. If we go to this other side, again it starts from the mandibular foramen, goes downwards and then forwards, passing through the submandibular gland fossa, and then again it goes anteriorly and loops back again in a posterior direction ending in the mental foramen. You can see that the mental foramen, in relation to its position to the apex of the lower 5 or the lower 4, differs. Sometimes it's well beyond or below the inferior dental, the apex of the 4 or the 5, and sometimes it goes up to be very close to the apex. Sometimes its image will superimpose on the lower third apical lower third of the root of the tooth. See, in this radiograph again the course is similar, and then it goes back again, and you can see here that there is a difference, a long distance between. This is the mandibular foramen, okay, then it goes downwards and then anteriorly and then it loops back again. See, the relationship here is, again, this is not the mental foramen, by the way, this is the mental foramen over here. So again, the appearances differs from one person to another. This is another radiograph. This is the course. See the looping, and you can see here that it falls distal to the apex of the lower 5. On the other side, you can see that this is the canal, then it loops back again. Here it is located mesial to the apex of the lower 5. So even in the same person, the appearance or the position, even in the same person, the appearance the shape I mean of the mental foramen, and the position differ. See, here you can see it's very clear. Mandibular foramen downwards, and then it crosses over here, and then it goes again to open in this side. While here, because of the radiolucency, this is the, by the way, this is the ghost image of the mandible, and this is the radiolucency, relative radiolucency of the submandibular gland fossa, so it is hard to tell where the opening of the inferior dental canal is, but we can trace it downwards, and then you can see it loops back, then it opens distal to the lower second premolar. Okay. In this radiograph you see that this is the canal, and then it goes again and it opens mesial to the lower 5. Again, it's almost identical from this side, where it can open mesial to the apex of the lower 5 as well. Here you can see that the opening is very close to the apex. Sometimes you will see it well beyond or below the apex, and sometimes it goes up. When we have a look on the periapical radiograph, the things will be a little bit different. Why? Because of the higher resolution of the image. One. Second is it's because we cannot trace fully the course of the canal, so there is a bit of misunderstanding. Anyways, if you see this radiograph, this is the lower 4, this is the lower 5. You can see that the canal opening is this one. Okay, and this is the looping of the canal. So this is the mental foramen. What we want to know here is that generally speaking, this should not be mixed with radiolucency of a radicular radiolucency. If we want to verify whether it is related to the apex of the tooth or not, we have to follow precisely the periodontal ligament space of the tooth to which the mental foramen is close. See, this mental foramen is closer to the apex of the, or it's actually located mesial to the apex of this lower premolar, but it's a good example to follow the PDL. We agreed that the lamina dura sometimes it disappears, so it is not our reference. If it is present, okay, we can follow it. If it is not present, then we follow the structure that will not disappear, and this is the PDL. You start following the PDL from the crest of the bone, and then you go down, 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 and then you see that the PDL continues as follows exactly the course of the root, wherever it goes, whether it is dilacerated or straight. As we agreed earlier, that the PDL, a healthy PDL, should have an equal thickness from the alveolar crest down to the apex in either side of the tooth. Now, the important thing here is that the PDL is continuous, and if the image of the mental foramen overlays the PDL, and then we are in a dilemma of whether this is a radicular radiolucency or not, our reference is the PDL. Let us know how. In this radiograph, you see that this is the course of the canal, inferior dental canal, and this is the looping back of the canal, and this is the opening of the mental foramen. This is a problem here. Why? Because the mental foramen is actually located exactly over the apex of the tooth. So, which is which? Is this a periapical a radicular pathology, or it is a mental foramen? Now, if we are asked this question from a radiographic point of view only, without clinical examination, then we have to do the following as we agreed. Better use a magnifying lens or you magnify the image if you have the tool, magnifying tool, and as we agreed, we follow what? We follow the PDL. The PDL should be continuous from the alveolar crest downwards up till here. Okay. Now I will enlarge more. You see that the PDL over here has not increased in size. I will increase more. Can you see the PDL over here? You see that the thickness of the PDL has not increased in this area. It means that the radiolucency that you're seeing here, which is the mental foramen, actually it is not part of the PDL. It is superimposed on it. If this radiolucency, if the PDL enlarges at this area, it means that the radiolucency that you see at the radicular area of the periapical area of the tooth is related to the PDL. But if the PDL continues in its thickness, equal thickness all over, starting from the alveolar crest downwards, it means that this, what you see here, is a superimposed image of the mental foramen over the PDL space. So here there is no periapical pathology. This is from a radiographic point of view. If this is your patient, then the radiographic appearance should be first preceded by a clinical examination to exclude any pulpal pathology that might lead to increase in the width of the periodontal ligament space. Here things are different, like a carious lesion or infected pulp canal space, or an incomplete apex, which is an important point here, and we have talked about the incomplete apex earlier. We said that always incomplete apex, especially in a growing tooth, takes the funnel shape. It will never assume the rounded shape. It is always funnel shape until there is complete growth or closure of the apex of the tooth, and of course here we must know the age of the patient. Okay, let's go to another case. Now here you can see that there is a pathology. This is the canal over here, and then you will see that the canal and the periapical area, they superimpose one over the other, and here we cannot tell which is which. But I think having this big radiolucency, almost the whole crown is destroyed by the effect of caries, and there is a root canal treatment being done over here. Now let's have a look at the PDL of the tooth. You see, if you follow the PDL of the tooth, here it is, I will enlarge. Here the PDL is normal in width, and then suddenly it balloons, and then it goes back to its normal shape or width. Now this is the mental foramen, and this area is a pathology. It could be a periapical granuloma, it could be an abscess or periapical cyst. There is a radicular pathology in this tooth. But how can we differentiate the mental foramen from pathology? Our reference is the PDL. Ballooning or increase in the size of the PDL, it is no more homogeneous in size or equal in size. It means that the radiolucency we're seeing here is related to the tooth. It is not related to the mental foramen. Of course, this should be combined by the clinical examination and the history of the patient. Another case over here. This is an extracted lower 5. You can see that the extraction site is recent. Our reference is the presence of lamina dura. When the tooth is extracted, there is no more PDL, by the way. What you see is the socket of the tooth, which is composed of the compact bone that surrounds all over around the root. Now, if this is the inferior dental canal, it loops back again. It is not covered in this radiograph, but it loops this way, and this is the mental foramen. Okay, you see that the mental foramen here is high. Okay, it's almost at the bottom of the middle third of the root, which was a root, by the way. Now let me enlarge and have a look. here our reference is the lamina dura. Do you see the discontinuation of the lamina dura? It is continuous, okay? Which means that this radiolucency you see over here actually is not a pathology related to this tooth, or which was there a tooth. Actually it is a mental foramen superimposed on the image of the socket. Our reference is what? The lamina dura. If the lamina dura discontinues over this area, okay, like in the previous radiograph or the PDL, we don't see a lamina dura here. That's why I always say don't follow lamina dura, but it is present, follow it. If the PDL expands, then the pathology is related to the tooth. If the if the lamina dura here in extracted side is continuous, it means that this is the mental foramen image superimposed on the socket of the tooth. Another radiograph over here. This is the mental foramen, and this is the apex of the tooth. Okay, there is a difference here around 4 to 5 millimeters, but again this is our reference, the PDL. PDL should be of even thickness starting from the crest down to the apex on either side of the tooth. Another tooth, which is a broken tooth, actually a broken root, sorry, of a lower 5, and here you can see again the PDL is continuous up till here, and then it suddenly increases in size, and then it goes back again to its normal width. This means that this radiolucency is never a mental foramen. Why? Because see the area over here, I will see the area here, then it is continuous, it is in line. This is the PDL, and then the enlargement or the ballooning of the PDL is related to the or the apical part of the PDL. This is because of the bone resorption over here. It is all related. It is not superimposed. Why? Because it is joined together. If there is a mental foramen here and there is no pathology, then we don't see this linkage or union between the PDL and the increased or the radiolucency which is surrounding the apex of the tooth here, over here. Okay. Another example. This is a lower 5. This is the inferior dental canal, and then it goes and ends up to open in here, and this is the mental foramen. Now this is a big problem over here. If we have if we are not sure of the clinical condition of the tooth, our reference, as I said, is the PDL. PDL, if it is continuous over this area, I will enlarge. See the PDL? It is continuous when it passes by the by the mental foramen. It means that the mental foramen image is superimposed on the apex of the tooth. Actually, this is even a bigger one because this is the mental foramen. This is the mental foramen over here. Loop, and this is the opening over here. It's all this is a canal looping plus the foramen. In either case, whether it is distal or mesial, the PDL is continuous, and this is a case that we often face when we work every day. Is this radiolucency related to the tooth or not? Here the level of the mental foramen actually is at the apical third of the tooth. As we said, as we have seen from the OPG, sometimes you see it over here. Depends on the anatomical variation, and it depends on how the radiograph was taken. I mean, from a geometrical point of view. Short radiographs will give you the impression that the mental foramen is high, while elongated radiographs will give the impression that the mental foramen is closer to the inferior border of the mandible. Another case over here. Okay, this is the mental foramen. Now, is this related to the tooth? No. Why? Because as we knew now, or as we know now, our reference is the PDL. PDL here is of even thickness. Then this radiolucency is a superimposed radiolucency of the mental foramen. If there is any pathology in this area, we don't see this even continuous line. We would see that there is breakage of the lamina dura if present, and then there is a sudden increase. The increase is in line with the PDL, but you see here that the PDL has nothing to do. It's continuous of even thickness, though, so there is no problem or there is no radicular pathology, at least at this stage where the radiograph was taken. Another radiograph over here. See, the mental foramen here is well below the apex of the lower 5, so it's clear here. Again, have a look at the PDL. PDL is continuous, lamina dura is continuous, and this is the mental foramen. Okay. Another case. This is the mental foramen. See that anatomical variation from one person to another. In the previous radiograph, it is down. The one before, it is over the apex. In other radiographs, it goes up to this level. So again, as we said, it is a matter of anatomical variation from one person to another. Mental foramen is distal to the lower 4. Though there is a big radiolucency in the crown, we can't tell of this tooth. Caries could be a caries cavity. We can't tell that there is a periapical pathology because the thin homogeneous PDL is still continuous. So this radiolucency you can see here of the mental foramen actually is not related to the PDL.